Thank you, Dr. Herman. And I'd like to also thank Professor Knecht for the invitation to come here. I think this has been an outstanding meeting. It's been a great opportunity for myself to sit and listen to and learn from many of the experts in the field. I think that all of us, as the last diehards who are here for the last session in this meeting would certainly agree that one of the things we're trying to do is to wage an effective battle against squamous cell carcinoma in our patients. And we know that with advanced disease, multimodality therapy is going to play a role in that. And it's really up to us to listen to the talks that we've heard to try to make decisions based upon evidence-based experience, and to try to really learn from and try to drive the optimal management of our patients with these problems. I'm going to spend a little time talking about the quality of life pertinent to surgery. This is a very broad topic and something that's going to be very difficult to cover in just a few minutes. This is not going to be a lot of hardcore data. I'm going to try to present some information that I hope will be provocative and allow us to discuss some things as we move into the panel section next. If we look at head and neck tumors, this is a very unfortunate gentleman, and I'm sure most of us have seen patients such as this who have gone through a course of multiple courses of surgery, radiation, chemotherapy, recurrent cancer, and shortly after he came to see me and I took this picture, this gentleman took a shotgun to his head and killed himself. This is a tragedy of what we deal with these types of tumors, and it's within this very small 6-inch cube. Nothing affects quality of life more than the cancer, and we can't lose sight of that. In terms of pain, function, cosmesis, the psychological impact of disease, clearly this is one of the most devastating diseases that we deal with. If we look at other specialties, oftentimes they're talking about things that are hidden behind the abdomen or behind the chest wall. As we all know, in the head and neck, it's right out there in front of us. The worst outcome, clearly, is to die of locally uncontrolled disease. We can't lose sight of that. All of us would like to have our patients die in somebody else's specialty. It makes it a little bit easier for us, and that's oftentimes a goal. But in actuality, they oftentimes don't, and dying in our own specialty, we have to recognize is not a very pleasant experience. So what of quality of life? If we look at quality of life in terms of the studies that are done, there are certain consequences of treatment that we have to always be aware of. The very common things such as facial disfigurement, speech impediment, problems and difficulties with swallowing and chewing, loss of taste, smell, shoulder pain, restricted jaw and neck motion are all things that we commonly talk to our patients about. But again, we've heard a lot of the new advances that have occurred in the management of head and neck tumors. We've spent a lot of time talking about new biologic modifiers, new cytotoxic drugs, altered radiation fraction courses, and yet we just touched on today at this conference some of the advances that are going on in the surgical management of our patients. And indeed, surgical advances are continuing on a regular basis in terms of our understanding of disease, new innovative ways to take out tumors, new approaches, minimally invasive surgery, a better understanding of the biology of tumors, partnering better with our pathologists to make sure that we're doing the right operations at the right time. And a lot of things can impact quality of life in a major way, and one would expect that one would have significant problems with certain tumors. This young lady that you see here is the youngest patient that I've seen that I've taken care of with a squamous cell carcinoma of the head and neck. She was 12 years old. I remember when I took care of her several years ago, she was the same age as my youngest daughter. My youngest daughter was worrying about zits on her nose and acne, and this young gal came in, had been treated for over 6 months, which was thought to be a large aphthous ulcer in the floor, mouth, and her tongue. She had a massive squamous cell carcinoma of the floor, mouth, and her tongue, extended submucosally to cross the midline and involved almost 3/4 of her tongue. This is this lady that you can see what we did. We took her through a tongue release approach, did bilateral necks on her, saved a good portion, the outer portion of the tongue, took out half of the tongue on one side, crossed the midline on the other, all the way to the back with the floor mouth. This young girl was reconstructed with a radial forearm flap. And fortunately, got actually a very good result. And 6 years later, here's her graduation picture in high school. One can see that this is not necessarily a morbid, mutilating operation. She has a neck scar that's barely visible that one can see here from bilateral neck dissections. She still talks well, and she wants to go on to become a physician. She's in college today. Obviously, a good report, and everything doesn't turn out well, but certainly it shows some of the unique things that we're doing right now with some of our minimally invasive approaches where radicality can be done when you have to be radical, and minimal can be done when one can do minimal things. So if we look at treatment of head and neck cancers, we know that they affect the fundamental aspects of life, such as this young person: eating, communication, breathing, appearance. But if we talk about quality of life, we also have to look into the other factors, such as social function, sexual function, job performance, how one interacts with other individuals. If we look at quality of life, there's two general domains that we have to study. One is the general quality of life issues in terms of how the patient is functioning at that period of time in their life due to their other medical diseases or their general conditions, both on a functional, physical, psychological, and social interaction standpoint. And also, how is the disease impacting their specific health factor? What is the head and neck tumor doing to them, again, in terms of functional limitations and emotional consequences, not only of the disease, but of any proposed treatment. We all know that we study performance status with our patients. Most of the patients that are able to undergo some of the more aggressive forms of therapy have to have very high performance status to be able to undergo some of the major courses of chemotherapy, radiation therapy, and even to do some of the major surgical events. But performance status is probably one of the most minimal attempts that we do to look at quality of life assessments. Now, were three questions that were posed to me as a speaker. Are there ways that we can look at the functional outcome of partial laryngectomies? What about the individual decisions that are made to treat patients with advanced tumors? And can we compare surgical and non-surgical induced side effects? I'm going to try to touch on these three questions very briefly in the next few minutes. First, what about the functional outcome of partial laryngectomies? This was actually kind of a surprise from the standpoint of what we did several years ago. If we look at this is a listing of many of the general multidimensional quality of life instruments that you've seen. Just the fact that there are this numerous number of general quality of life indications tells us that nothing has been universally acceptable, satisfactory, or has achieved good validity and good usable results. One important aspect of it. Otherwise, there are specific ones pertinent to disease of the head and neck itself. Again, a huge listing, and one can pick and choose from these, and indeed at our institution we do pick and choose from several of these as we've tried to develop some of our own quality of life assessments. But if we look at laryngeal cancer, we have to go much beyond just voice and breathing and speech. We have to look at what's happening to our patients in terms of how does their disease impact them with work, spouse and family interactions, sexual interest and performance, financial repercussions of missing work, social and recreational activities. Several years ago, we did a study looking at patients of three groups: partial vertical laryngectomies, people who had near total laryngectomies, and total laryngectomies. One of the biggest impetuses to doing this study was to try to see how were we impacting our patients' quality of life in general, but more specifically, what was the real impact of voice, and how important did patients view their ability to talk and speak effectively. Again, a big surprise came out of this study. We looked at their general aspects of quality of life with the psychosocial adjustment to illness scale and a Mayo Clinic post-laryngectomy questionnaire. What did we find? Clearly, anytime we did surgery in the larynx, it affected all aspects of the patient's life and changed the lives of those around them, but in a very surprising manner. 74% of our spouses and patients found that the relationships were as good before the operation as they were after, but 25% clearly had some effect. A third of the patients had marked loss or no interest in sex afterwards, something we don't think about or talk about a lot. About 1/3 of them felt that they had not made a good adjustment to their operation. About 2/3 felt that they had, and this was in the group that had had total laryngectomy. But what about speech? Speech was probably one of the most surprising things for us of all. We found that the individuals who had had a partial operation or near total operation or total laryngectomy all reported the same generally good effects with speech. Up to 80% reported excellent or acceptable communication skills, whether they were treated with radiation therapy, had a laryngectomy, had a partial removal, had a laser excision. And so whatever the altered speech was, and we could go into numerous ways to try to assess altered speech, it all seemed to lead to a good quality of life. Now, these results are often very counterintuitive. One would expect that if the voice is altered, quality of life is going to be altered poorly. But again, this has been shown in other studies looking at laryngectomies. People who have had chemoradiation therapy, partial laryngectomies, have really shown that there was no difference in speech quality of life initiatives or scores. Performance scores for speech have been similar, whether you have larynx preservation or laryngectomy. Again, because there are ways to rehabilitate speech after total laryngectomy. The general quality of life domains, as we heard in an earlier talk, are basically the same for chemoradiation therapy as they are for surgery and followed by radiation therapy. What do we know? We do know that the presence of a stoma clearly has a negative impact on patients' quality of life, sexual performance, adjustment to operations, and the stoma may have much more of a serious impact on life adjustments than voice alterations. So if an individual does not have a stoma, and they have an altered voice, and they can swallow, there's no reason they shouldn't have an excellent quality of life. So the absence of the stoma and normal swallowing, which occurs in most patients who have a partial operation, whether it's laser or an open operation, should lead to normal quality of life. What about the individual decision on how to treat people with advanced tumors? An incredibly complex subject, again something that we could spend hours talking about in a session such as this. But I've always found when I hit my individuals who have advanced tumors to go back to some of the very most important basics and look at what are the factors that arrive at those decisions. Understanding the tumor, how the tumor is behaving in the patients, its growth rate, its level of aggressiveness, understanding the surgeon's experience, knowledge, willingness, expertise to take on problems, understanding what the pathologist tells us both in terms of the neck and the primary lesion, and understanding issues pertinent to the patient and what does the patient want as we look at some of these very difficult decisions. What are some of the important factors? I can't emphasize enough that we can't overlook comorbidity. We have to measure it, we have to assess it, we have to look for it, and if we're going to make any impact on overall survival in head and neck tumors, it's only going to come if we're willing as a specialty to step up and start addressing comorbidity as much as we address many of the other factors with our patients. Alcohol use is another thing. If we can go on with our patients and not address smoking and alcohol use and hit alcohol very effectively and hard, we're going to have little impact because of severe comorbidity and overall survival analysis. Tumor behavior, T&M reporting issues obviously are other things that go into the equation about what to treat. So if we look at the advanced tumor patient, what do really patients want? Patients want to be cured of their cancer. They want to swallow normally. They don't want aspiration. They don't want stenoses. They don't want tubes. The number one dissatisfier in quality of life initiatives for patients is the presence of a gastrostomy tube, bar none. Study after study have shown that. Patients want to talk. They don't want a stoma. They don't want tracheotomy tubes. They don't want complications. They want to reduce uncertainties. They want to have absence from pain. And if they can, they prefer single treatments. What about the whole issue of quality of life for advanced tumor patients and our treatment decision planning? Again and again we hear this concept of mutilating surgery. What is really mutilating surgery? Is mutilating surgery the surgery we do in that young 12-year-old girl? Is mutilating surgery to take out someone's larynx? Or is mutilating surgery to take out a small tonsil cancer? I think these are things that we really have to ask as we start to hear what these terminologies mean. And again, it's very difficult to try to compare treatment performances across this country and across the world and across even our own state when we look at different centers and we say what's their experience treating oropharyngeal cancer or conservation laryngeal operations when many people don't even perform any of those operations. And what is truly advanced? We see this happening all the time. We've talked about this already at this conference. We can look at things that is a T3 and T4 advanced or is a stage 3 and stage 4 advanced. What about a supraglottic cancer? A T1N1 is a stage 3 or a T3N0 is a stage 3. a very different patient if that is a mobile cord or a fixed cord. And how do we report quality of life outcomes if the indications for different procedures are not even comparable? If we look at the veteran study and RTOG 9111, the two studies talking about chemoradiation for organ preservation, we know that about half of those patients with excellent performance scores had mobile vocal cords. I can't even think of the last time that I had to take out a larynx and do a laryngectomy on someone who had excellent performance status with mobile vocal cords. And yet this accounts for half of the patients in these two studies. So when a patient comes in to see me right now and they have a fixed vocal cord, I have to honestly tell them, I don't know what the results of that are. We can postulate, but it still hasn't been shown in the literature. As simple and important a factor as the results of fixation of a vocal cord, true fixation, we still don't know the answer to that. And what about organ preservation philosophy when we're talking about preserving the tonsil or half of the tongue base? I've not seen a whole lot of functional benefit to preserving someone's tonsil, and yet there's no question that we have said again and again as an organization, the tonsil and tongue base are an organ that we're not going to operate on any longer. We're going to give that up to chemotherapy and radiation therapy because of good results. There are multiple ways to get good results, but I would challenge most people in the room to say, what is the real benefit to preserving a tonsil? I'd like to go over a case report. And this is a case report in terms of advanced tumors, not to show some small tongue-based tumor that was treated with the larynx and a neck dissection that went home in a day, or a small individual who had a tiny tonsil cancer that was taken out transorally with a neck dissection, which I think many of you do on a regular basis. But this was a 53-year-old male. He was a former smoker, occasional alcohol use, 4-month history of throat discomfort. He had dysphagia for solid foods, a very hot potato voice, increased snoring, vague fullness in his throat, 1 episode of hemoptysis, and a 10-pound weight loss. What did he have in clinical examination? A large exophytic lesion in the left tongue base that extended deep into the tongue and into the vallecula, didn't cross the midline. The mandible and larynx were not involved. The neck had a single mobile mass, 3 by 3 centimeters in the left upper neck. Biopsy in the office showed grade 3 squamous cell carcinoma. We did imaging studies and had to meet with people and discuss treatment options. Imaging studies showed the single mass in his neck on PET scan with a large mass in his tongue base. We reviewed the tumor's extent, talked to him about options, and the decision by this gentleman was made to proceed with surgical resection of this because we felt that we had a very good chance to preserve good function, to remove his tumor, and then proceed with postoperative radiation therapy. This individual underwent a tracheotomy, a left complete neck dissection, has excision done by a parasymposial mandibular osteotomy, resection of his tumor, had some secondary healing of the mid portion of the tongue base, closure of a portion of it laterally. Here's the picture of his excision, or exposure, after his tumor's out, and closure. And interesting, what did our pathologist find? 2 separate primaries in the tongue base. One was 4.4 by 2 by 1.9. The second was 1 by 1 by 1, separated by normal mucosa. And in his neck, he had 4 positive nodes. The largest was 2.6. This is the individual after his surgery and radiation therapy.
When did you have your surgery done?
July of 2000.
How's your swallowing now?
It's very good.
And what about your voice?
My voice is excellent.
Okay, cut. Stick your tongue out, move the right and left. Okay, very good. Back to the middle. Up, tongue up, and down. Good, that's fine, stop. Okay. Now can I say E? Again, E.
That's enough, we can go on.
Count 1, 2, 3.
Just click off, thank you. This individual is now over 5 years doing well after that operation. So when do we really take on the difficult or the realistically inoperable or the real challenging cases? This is a lady I saw not too long ago who came in literally living as a hermit behind a gauze in a small town in northern Minnesota with a very extensive basal cell carcinoma. And she finally came in because her goal was to try to save one eye to allow her to continue to see. And that was her only goal that she wanted to do. She had pain, she had drainage, she had a very extensive lesion. And yet, from a quality of life standpoint, the goal on this lady was to try to save one eye for vision. This shows her resection after we finished, literally having to take off all of the structures off of the globe. We were able to save her eye back to the optic nerve, removing a significant portion of dura, maxilla. Is this good quality of life for this individual? This lady was very, very happy. I can tell you, to be able to see, to not have any pain. But again, is it cosmetically acceptable? It looks ridiculous. You know, it's a cosmetic disaster, but again, she's a disaster to start with. What about this individual who had multiple courses of surgery, radiation therapy, comes back in with pain, a large mass filling his mouth, neck, surrounding his carotid artery? This is an individual who went through some temporary balloon occlusion tests to see if we could sacrifice his carotid artery. We placed some detachable balloons in when we found out he could sacrifice them. Took him to the operating room for a completion, mandible, floor, mouth, major part of his tongue, and a complete neck dissection with removal of the complete external carotid artery. He was treated with a free flap reconstruction based on his transverse cervical vessels and a pectoralis flap for outside skin coverage. This individual later had a metastasis to his lung, had a thoracotomy and had that removed, and he is one of these rare individuals that has still survived something that I would have thought his chance of survival was about 0. But how are we going to improve quality of life? We have to address comorbidity. We have to look at these causative factors, tobacco and alcohol. We have to manage anxiety and depression. The last individual I showed you, the minute he left the hospital, he went into alcoholic treatment unit, and he's been in regular contact with our psychiatrist due to significant anxiety and depression. He can't eat at all. He is permanently fed by a gastrostomy tube. And finally, can we compare surgical and non-surgical induced side effects? You know, when we talk to patients, patients have almost no way to try to perceive what's the risk to their quality of life if their tumor recurs. It's probably one of the most difficult things of all for them when they try to compare various forms of treatment. Anytime there's recurrence in any subsequent treatment, it's usually much worse on quality of life than any initial treatment would have been. And I think that those of you who do head and neck surgery will realize, and do realize, that your patients will tell you that the morbidity and results of their long-term sequelae have been less with surgery than with other forms of treatment. And that's, I think everyone would agree with that. And there's no question that as we combine treatments, the morbidity of our patients does go up. But again, a dead patient doesn't do us any good at all. And oftentimes we run into problems such as this, which I look at this as non-fixable problems. We talked about issues with necks today. This was an individual that was sent to me by one of our former residents who had gone through a course of chemoradiation therapy for a larynx cancer. The tissues fell apart. He had tried to close it. He sent it to me to see if there's anything I could do. I looked at this patient. I said, there's absolutely nothing I can do for this individual. This individual blew their carotid artery out about a week later and died, went into a hospice program. And what about this individual? This person, I can tell you, was a personal friend of mine. He was in Rochester. He was a minister, was one of the best squash players I've ever played with in my life. He and I played squash together all the time. This particular individual moved out of town and developed a tongue-based tumor and was treated with chemotherapy and radiation therapy. He's over 3 years. He may be cured of his tumor. I hope he is. But this individual has preservation of his organ, but he has no absolute function. He has a gastrostomy tumor with a complete stenosis, over 10 centimeters in length, that cannot be fixed, a tracheotomy that we barely are able to keep a tracheotomy tube in without fibrosis and scarring with the tracheotomy tube. Trismus, he does not live a good life, I can tell you. And yet, it's a constant battle that we have to look at in terms of what are we preserving and what are we doing for our patients. The problem is, if we look at the data set for surgery alone, our data is very poor when it comes to quality of life issues. Small numbers, small studies, not a lot of good data. If we look at combined treatment, how do we assess what's an effect of surgery, what's an effect of radiation? Should we be doing quality of life studies of surgery before radiation or before chemotherapy? When should we stagger these? These are all very important issues that we need to discuss and follow up on. Timing is key, and if we don't follow people for a long period of time, we're going to miss many of the impacts of what we're doing to our patients. Just as an example, if we look at a study that was done from Olsen looking at osteoradial of oropharyngeal cancers, and those patients who developed osteoradial, when did it occur? 42% of them had occurred at 2 years, 50% by 3 years, 82% by 5 years. If we're not following patients out for a long period of time and we're doing it for 6 months, we're missing impacts on quality of life. The issues of delayed and progressive fibrosis and stenosis or detection of other tumors have to be followed for a long period of time. In general, patients with combined treatment, surgery and radiation, report that quality of life was more negative with radiation than with surgery. But I can tell you that the patients that I've seen who have had surgery and radiation, in general, have reported to me better quality of life than the patients that I send for chemotherapy and radiation therapy. And the worst of all are the ones that have surgery, chemotherapy, and radiation therapy. So the combined modality seems to grow on itself, and we have to continually look for ways that we can reduce morbidity on our patients, whether it's eliminating surgery, eliminating chemotherapy, radiation, adding biologic modifiers, or doing different sequencing. Quality of life encourages us to look at what we're doing carefully, to look at the totality of how it affects our patients. Evidence-based medicine is critical as we look at how we study these. It complements experience and intuition. I'm reporting a lot of anecdotal data today. Anecdotal data is generally useless. You have to look at this strictly as somebody's experience. But it becomes important as you look at the individual care that any one of us is offering our patients and when we get into treatment planning. One of our big concerns is how much time do any one of us actually spend with our patients? Do we have enough time as physicians to adequately assess and manage their pain, to look at their forms of rehabilitation that are necessary, to look at their psycho-oncology that's important, and to really assess palliative care? We would like to do this as physicians. The reality is we need a team to help us do this if we want to take the best possible care of our patients and achieve the best possible quality of life. How are we going to assess quality of life in the future? I'm convinced that quality of life is going to come from the field of radiology. And that may seem like a very strange thing. You could say, why radiology? The advances that are going on in radiology today are so fast and accelerating at such a rate that we can sit down right now on a CT scanner, do a 3D reconstruction of the esophagus, and sitting at your terminal, go down and do an esophagoscopy on your patient. We can do the same thing with laryngoscopies right now on the basis of 64 scanned CTs, putting them back together again. I could show you images of the functions of beating hearts, looking at how individual hearts work. You certainly can tell that we're going to be able to very clearly assess how well do people swallow, how well do they talk, how much they cough on the basis of imaging. It's going to be easy to do as we look at recurrences. It's going to be easy to do as we look at in the future for function. So if we look at quality of life and outcomes in head and neck surgery, we really have to look at what criteria are we using to measure success. Survival data in and of itself is not enough. We need to continually understand the full impact of what we're doing to our patients with head and neck cancer. We're impacting multiple areas of their life. And there are unintended consequences. We can't just look at organ preservation. We have to look at organ function and the other aspects that go with it and not draw unwarranted conclusions. We have to really ask ourselves, have a lot of the changes that have gone on right now in the head and neck field, have they really led to improved outcomes and improved quality of life for our patients? If the answer to that is yes, we should continue it. If the answer to that is no, we should not worry about continuing to look for new methods. And we have to constantly look at what time period are we studying things, because results at 6 months are very different than results at 3 years. So for those few thoughts, I thank you very much. It's been a great conference, and I'll look forward to the panel. Thank you, everyone.